All right. Well, welcome back. We are going to review difficult oxygenation in the context of managing patients, specifically around when we're managing with a bag valve mask. But these principles will apply to any patient with a low oxygen level. So the first thing is, how will we pick up on a low oxygen level? I guess we'd have clinical findings. We could have central cyanosis or peripheral cyanosis. If we had severe hypoxia. Additionally, in our SpO2 monitor, we would see a low oxygen reading for that patient in front of us. So we would want to address that. And when we address that, it's important to consider the causes of hypoxia. Now, I like to always tell people, especially if we're breathing for patients, is that we have to establish an appropriate minute volume. And then, excuse me, an appropriate minute volume, so appropriate respiratory rate and size of breath, which would be represented in air entry, in apices and bases, as well as an appropriate end tidal CO2 to start off. Because the most common cause of hypoxia is just from not actually ventilating adequately. So hypoxemia can be caused by hypoventilation. And obviously, if you don't move enough air in and out of your lungs, then you're not going to oxygenate appropriately to be able to push that air oxygen across through the alveolar membrane into the blood. So causes that could lead to that would be things that would decrease your lung surface area. That could be disease pathologies. You could have a pneumonia or ARDS that could lead to an area of atelectasis, so an area of the lung that's not getting ventilated, that air is not going in and out of. You could also have poor solubility of that oxygen going in, whether there's something in the way like pulmonary edema. You could also have an increased kind of alveolar wall as far as membrane thickness. That could be from fibrotic lung disease, chronic lung disease, COPD, these types of things increased with like inflammation and also mucus production. And we could also have a decreased pressure gradient. I guess if we were high up in the mountains, that doesn't happen as often. So diseases that could cause these things would be COPD, asthma, any kind of pulmonary vascular disease, including pulmonary embolism. Now, the pulmonary embolism wouldn't be a problem on the airway side, but would be a perfusion of the blood getting to the alveolar kind of bed. And would nonetheless lead to hypoxia. In addition, you could have interstitial lung diseases that would increase that. So the first thing when I turn to a hypoxic patient and look at them, you're right to consider, are we breathing adequately for this patient? So the things that we can do is establish an appropriate air entry and CO2 for the patient. After that, if oxygenation is still not adequate, we can sit the patient up. Patients greater than 30 degrees are correlated with higher oxygenation levels. The other things we can do is add more oxygen to the patient. So if you're ventilating through a bag valve mask, you could add a nasal cannula underneath. A high flow nasal cannula would be ideal. The other thing we could consider is adding in PEEP. And with PEEP or CPAP, we'd have to be more cautious in hypotensive patients and also in patients with restrictive lung diseases like asthma. We'd have to be a little bit more judicious like that. And then targeted therapies to the disease that we're treating. So if this was asthma, getting some Ventolin, Atrovent on board, those would help increase decrease areas of atelectasis, increase the amount of alveolar that exposed for gas diffusion. We could add steroids into that mix to decrease inflammation, to decrease the membrane thickness at the alveoli. So those would be the first and most common area that you would find hypoxia. Now, there is some other causes of hypoxia. And let's first talk about the circulatory system. Now, we could first of all think anemia. So if you don't have the appropriate amount of blood, then you can't oxygenate your tissue well. So whether you have trauma or just have an anemia as a result of any other condition, we won't dive down too far there, but that could lead to hypoxia. And obviously that would require a blood transfusion in lots of cases. The other in the circulatory system is that we don't have adequate blood pressure. You're in some sort of shock state, whether that could be cardiogenic shock, septic shock, through where we're not perfusing into the tissues. So if you have a saprobate on the fingers and you have a low blood pressure, it wouldn't be uncommon for you not to have a good waveform on your saturation on the monitor, but also a low number just as a result of as that blood traveling slowly through the body and getting deoxygenated as it goes. So that would be necessary to think about. Additionally, we should think about if there's something that's altered the way that oxygen wants to bind to hemoglobin. Remember that when the way that your body's designed is that if you have a localized area that you have increased CO2. Picture if you go for a run, what happens in your muscles when you go for a run? You increase the level of CO2, you increase the amount of acid or decrease the pH. You decrease the concentration of oxygen. That's all an environment where hemoglobin likes to give oxygen away. Now, in an isolated environment, that's great. That's how your body's supposed to work. Whereas in a condition like sepsis or untreated renal failure or severe diabetic ketone acidosis, we could toxicologies like TCA overdoses, you can end up in severe metabolic acidosis, and those would lead to a patient that their hemoglobin doesn't like oxygen as well, both when it comes through to the lungs to pick it up, but also drops it off very easily off at the tissues. So those patients would have to be ventilated more. And if you had a patient that you weren't begging for and you walked in the room, and those patients, if they were metabolically acidotic, would often have a high respiratory rate, a lower SAT. And if you put an end-tidal CO2 on them, their end-tidal CO2 would often be low because they're breathing off and trying to get rid of their extra acid through the process of breathing in CO2 and water. As part of that process. So that's another reason why you could have a decreased oxygenation to a patient is you could just have a septic patient and they are offloading quicker because of their sepsis. We have other conditions that we don't run into as often, like histotoxic hypoxia, like things like cyanide poisoning. Those are a little bit more less common, but it's important for us to consider those as we approach those patients. So when you come into a patient that you have adequate or have poor oxygen saturation, the first thing I want you to think about is, do I have adequate minute volume? Do I have appropriate chest rise and fall, tidal volume, able to hear air entry, apices and bases? Do I have an end-tidal CO2 that's appropriate for the patient that's in front of me? Most commonly, that will be a CO2 between 35 and 45. A little bit different, would typically be a little lower in a metabolically acidotic patient. After those things are managed, then you can consider, well, if we have those, the things that we can do to increase oxygenation is sit the patient up. Sitting the patient up, we'd want to be a little bit more cautious if we're hypotensive. We can increase the liters of oxygen. That's pretty easy to do on all patients. And we could consider PEEP and caution in the PEEP or the CPAP in patients that are hypotensive or are air trapping. So those would be the major interventions that we have to do. And then if your oxygen saturation still aren't great, do a run through and visualize that oxygen molecule going down through the upper airways into the lungs. Do we have any pathologies in the lungs on the lung side? Then do we have the blood there? Is the blood moving around the system appropriately? Is the conditions of the hemoglobin molecule appropriate, that it wants to pick up oxygen appropriately and drop it off appropriately? Are the cells able to use oxygen in the case of cyanide? Now, I know that would present in a different setting, but all things to consider as we approach a patient and how they could end up with hypoxia to the tissues. So those are the major things. Next video, we'll jump into talking a little bit more about CPAP and PEEP and how that can be used to increase oxygenation.